Syncope is a transient loss of consciousness caused by a brief reduction in cerebral blood flow. There are different types of syncope. The most common is reflex syncope, also called vasovagal syncope. This type often has warning symptoms, such as warmth, pallor, or nausea, before the episode occurs. The episodes are usually short, and recovery is rapid. Other reflex causes include situational syncope, which can happen during coughing, sneezing, swallowing, defecation, or urination, and carotid sinus hypersensitivity, which may occur when wearing a tight collar or turning the head. Another type is orthostatic syncope, which is related to low blood volume, the use of medications such as antihypertensives, or autonomic nervous system dysfunction. Orthostatic hypotension is defined as a drop in systolic blood pressure of 20 millimeters of mercury or more, or a drop in diastolic blood pressure of 10 millimeters of mercury or more within 3 minutes of standing. Cardiac syncope is another important type. It can result from arrhythmias or from structural heart problems such as aortic stenosis or hypertrophic cardiomyopathy. Moving on to infective endocarditis. This is an infection of the endocardial surface of the heart, and it typically involves one or more heart valves. The infection is most commonly caused by bacteria and much less commonly by fungi. There are two main forms of infective endocarditis. Acute endocarditis is classically caused by Staphylococcus aureus, a highly virulent organism. It produces large, destructive vegetations on previously normal valves and has a rapid onset. Subacute endocarditis is classically caused by viridans streptococci, which are less virulent. In this case, the vegetations are smaller and usually form on valves that are congenitally abnormal or already diseased. Subacute endocarditis often follows dental procedures, and the onset is gradual. Patients typically present with fever, which is the most common symptom, along with a new murmur and signs of vascular or immunologic phenomena. Vascular findings can include septic emboli, small red spots on the skin called petechiae, splinter hemorrhages which are thin, linear bleeding under the nails, and Janeway lesions which are painless, flat, reddish spots on the palms or soles. Immunologic findings include glomerulonephritis from immune complex deposition, Osler nodes which are painful raised purple lesions on the fingers or toes. Remember O for ouchie, and Ross spots, which are retinal hemorrhages with pale centers. The mitral valve is the most commonly affected, followed by the aortic valve. In contrast, tricuspid valve involvement is strongly associated with injection drug use. A useful way to remember this is don't try drugs. There are also special associations to know. Prosthetic valves are commonly infected by Staphylococcus epidermidis. Gastrointestinal or genitourinary procedures are linked with enterococcus infections. Colon cancer is classically associated with Streptococcus galliticus. Infections by gram-negative organisms known as the HASEC group, which includes Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella, can also cause endocarditis. Culture-negative cases are often due to organisms such as Coxiella or Bartonella. In patients with injection drug use, Staphylococcus aureus, Pseudomonas, and Candida are common culprits. The pathophysiology involves endothelial injury, which leads to the formation of vegetations consisting of platelets, fibrin, and microbes. These vegetations can damage valves, cause regurgitation, and break off, leading to septic emboli. Emboli from left-sided endocarditis typically enter systemic circulation, while those from right-sided endocarditis travel to the lungs. Diagnosis requires multiple blood cultures and echocardiography, which can directly visualize vegetations. There is also a related condition called non-bacterial thrombotic endocarditis, sometimes called marantic endocarditis. This is a rare, non-infective form where sterile, platelet-rich thrombi form on the mitral or aortic valve. These vegetations dislodge easily and can cause emboli. It is usually silent until an embolic event occurs. Non-bacterial thrombotic endocarditis is often associated with a hypercoagulable state, particularly in advanced malignancies such as pancreatic adenocarcinoma or in systemic lupus erythematosus, where it is referred to as Liebman-Sachs endocarditis.